Welcome to Joint Effort PAs, where two orthopedic surgery PAs get real about life in medicine. From tips and tricks to professional growth, work-life balance, and everything in between. We're here to share what we've learned and what we're still figuring out. Let's get into it. We're going to switch gears a little bit today and do something ortho-related and actually talk about some orthopedic pathology. And I think we need to start including this a little bit more intermittently.
I agree. I think clinical scenarios and clinical syndromes like we're going to talk about today, it's almost like a sounding board for the stuff that we see all the time. So I don't think we're going to tell people how to do their job and like arrive necessarily at diagnosis, but how to work through various thought processes with certain ailments.
Yeah, like brief overview. I feel like these are things that, obviously you can get a ton of information on the internet, and we're not going to like delve into the details of exactly, all the anatomy and how to specifically treat every little thing, but we will get to like a brief overview just so that you're aware and it's on the forefront of your mind. Okay, so we are going to talk about hypermobility syndromes in orthopedics. We came to this, I don't know how.
I've had like the past 2 months, I've seen a lot of this.
Yeah.
And I don't remember how we started talking about it, but there's a lot of overlap in you do hand and wrist and I do shoulder and knee. And those are, three very common joints where you're going to see hypermobility syndrome. But I also think like it piques my interest because what you read about it and then what you see clinically, it's one of those things where the textbook doesn't necessarily translate to actual practice.
I don't know that I learned about it in school. I don't know that we talked about it at all.
Well, that's one example. I don't think that it was something that I thought was as common as it is until I got into, shoulders and knees, essentially.
Yeah. So this is, cue the patient who calls themselves double jointed.
Yes.
Or don't always present in that way, right? Like sometimes they just come in with vague pain that you cannot explain with anything else. And they're typically a younger patient population, female, more common. Mm-hmm. But these people walk in more frequently than you think. So first we will kind of just go through and define what hypermobility is. So 2 types, generalized versus localized, meaning that you can have, generalized or systemic disease based hypermobility versus like 1 or 2 joints that you have that are hypermobile.
And do you see, I see generalized way more than I see localized, unless it was like injury related or something like that.
Yeah, I think so. I would agree. So Beth, what are the generalized ones that we see a lot?
So we see a lot of Ehlers-Danlos syndrome, whether patients have it or not. And I like to call it Ehlers-Danlos with like variants. So some people have that. So generalized hypermobility, connective tissue disorder. And it's that patient that has like that doughy skin, and can really hyperextend the elbows, hyperextend the knees. Their parents have the same thing. So we see that commonly. Whether someone is officially diagnosed with that or not, I don't think patients have that diagnosis. Like, I don't think that that's something growing up going to a pediatrician, the pediatrician's like, you have this,
Marfan's maybe, because typically patients with Marfan syndrome there's an appearance to it and it's more noticeable. And also there's more like cardiovascular implications with Marfan's disease that are concerning. So I think that's probably more frequently caught, but Ehlers-Danlos, not so much. And that's actually like a tricky diagnosis to arrive at. You have to go through genetic testing. And honestly, like, I don't even know what all the testing process entails other than it's hard to get that diagnosis.
Yeah. And I've taken patients down that road before. And I think there's a specialist in Duke, but again, like to have the diagnosis of that, like there's no medicine for it. It's almost like, I don't know. I'm kind of like divided when patients are like, should I go get the genetic testing? Like you can, but it's not going to change anything.
Yeah.
I guess it's more of an awareness of how to deal with the symptoms that you have.
Or just like a label to what you're experiencing. Cause sometimes it's just helpful to have that label. Yeah. But you can also have different forms of the Ehlers-Danlos, like vascular implications of it. So, I guess from that standpoint, like, if you're not purely having the musculoskeletal issues, then there's some reason to get it worked up further, right? Because vascular stuff's important. I don't really know know too much about the heart, but I think it's important.
Definitely more common in females are teenagers, and those that are in sports that require a lot of movement. Again, that's a dumb sentence, but like dancers, gymnasts, you'll see like overhead swimmers, right? Swimmers, volleyball players, those that require excessive hypermobility for their sport.
Softball pitcher.
Yeah, exactly. Yeah. So we'll see them, well, again, being in orthopedics, we'll see them when they're problematic in athletes. But I would say that typical patient is female, teenager involved in sports, has been complaining about, let's say, knee pain, shoulder pain, elbow pain, wrist pain without injury. Doesn't necessarily stop them from doing their sport, but their parents will bring them in when they're like, she just keeps complaining about it. Yeah.
And this is different than, so you can have the generalized, like we said, and then you can have localized, which is just, one or two, a couple isolated joints where you have hypermobility at. And this can be traumatic or atraumatic. We're focusing more on atraumatic joint hypermobility. Traumatic joint hypermobility is its own other thing. You have a lax ligament because you've injured said ligament, and that's a different story. So, okay. So how do you evaluate these people? So Beth, if somebody comes in and, vague, diffuse shoulder pain, and you're kind of already suspecting this based on the age, the sport, just the type of person sitting in front of you, what is your exam for the shoulder typically?
Yeah. So I will see a patient. I think for our shoulder patients, it's any throwing athlete, if it's their dominant arm, swimmers, or overhead athletes. So they'll come in and let's say it's a softball player, let's say it's a boy and it's a baseball player or something like that. And they'll complain of one painful joint. And it's so vague. And again, trying to interview a teenager is also vague, right? Yeah. So, baiting them with questions. Like first thing is, was there an injury? No injury. Okay. Is the pain so bad that it stops you from doing things? No. But it just hurts during, let's say it hurts with overhead things or it hurts with throwing, and it doesn't hurt with other activities. Like it doesn't hurt to get dressed. It doesn't hurt to sleep. It doesn't hurt to eat. But I think typical complaints is popping, or it feels like it's quote shifting, or if we're lucky, they'll say my shoulder doesn't feel stable, or it feels loose or something like that.
Or it's popped out a million
times. Yeah. But like, again, atraumatically, oh yeah, my shoulder pops out all the time. And then they'll roll their shoulder back and literally show me that it pops out very atraumatically. And I will ask them in the middle of that, I'm like, oh, are you double jointed? Because I think that translates to patients because they kind of know what that means. And they'll literally straighten out their arm. And it goes 20 degrees hyper, and they're like, no, I don't think so. And I'm like, oh, no, that's hyper. No, that's not normal. Yeah. But it's so funny because those patients that don't know that they have that, when you point it out, they're like, oh, that's not normal.
Yeah.
I guess, it's they don't know.
Well, because somebody in their family probably had it too. And they were like, oh, this is how we all exist. Yeah. And also, like, depending on your sport, it's advantageous to have that level of hypermobility. So everybody that you're participating with, like high level gymnasts, you all have it.
Yeah. So take home from what we've learned in school and maybe more so in practice, how do you classify this? Talk to me about the scoring that you will look at.
Yeah. So we have the Byton score, I would say is the most commonly used one to assess it. So couple of points for that. So you get 1 point for each laterality for each of said things. So one is being able to extend your fifth MCP joint, so at your knuckle, past 90 degrees. I cannot do that. Beth, can you do that?
I cannot do that. And even if I try, like that hurts me.
Yeah. This is painful. Apposition of your thumb to forearm. I actually can do this one.
Oh, I can't do that one.
It hurts a little, though.
Do that all the time.
Yeah.
Like I can do that. No, I still can't do that. Nope.
Yeah, no, not quite. So we're good so far. Hyperextension of the elbows past 10 degrees. I do.
Oh, you too?
I do. Yeah. I have that one.
I don't. Mine don't even. Well, mine barely goes straight. So
okay. So Beth is still 0 for 0. Yep. Hyperextension of your knees past 10 degrees. Can't do that.
Can't do that.
And palms flat on the floor with your knees straight. Like if you're trying to touch the floor, toe touch, but your palms have to be flat on the ground.
I have never been able to do that.
I definitely can't do that when I can like reach down with like the tip of my index finger maybe and touch the floor. So I would score somewhere around a 3 to 4 on here. And Beth Beth is 0.
I'm a 0. Yeah. But I think you can, interviewing the patient, you're not sitting there and you're asking them to do these things. I will look at their elbow, their knee, and then see if they can bend over to touch their toes. And from that point, once you have like 3 or 4 of those, it's kind of going in that direction.
Right. Yeah. And the interpretation they say is greater than or equal to 5 for adults. Generalized hypermobility syndrome, kids greater than or equal to 6, because we expect kids to be a little bit more lax.
Yeah.
But yeah, I mean, and I agree. I'm not going to like typically have people do all of the things.
Right.
If I'm examining them for a hand or wrist issue, I may do the upper extremity stuff in isolation. And if I'm getting very intrigued, right, and this looks like somebody who is very, very hypermobile, I may complete the entire bite and score for myself.
Yeah. Oh, yeah. No, that's personal. Just to see like how.
Yeah. Like how are we going to get all the way? Like,
but it's funny because when you're in the room and you've got the patient doing that, you've got the mom across the room and she's like, oh my God, me too. Yeah.
We're all doing it
why
together.
We're here. Right. Mm-hmm. So do you think genetic testing is necessary? Like, how many times have you been asked by a patient, especially if you go through that and then you have this eye-opening moment where like, oh my God, oh yeah, I guess I am hypermobile.
Yeah.
How do you weave that into the conversation? I never bring up, do you want to be genetically tested? But the patients will. So do you think it's important?
Yeah. Some people, first off, don't know that that's a thing or how you arrive at the diagnosis. And we have to have that conversation first, that it's genetic testing. But I have had a couple of patients ask me if I could refer them for it and if they should. And in my experience, at least in this general area, I don't know what it's like other places, it was very difficult to get people in for that referral. Like I've had patients wait close to a year for the geneticist. And then the patients who I have had go see them, they're like, well, I don't really do anything. And I mean, they're not going to do anything. And so that's what I tell them. Like, yes, we can put in that referral if you would like to undergo the testing and, just arrive at that diagnosis and have somebody tell you that face-to-face that this is what it is. But we're going to treat you the same. Like, I don't have anything different to offer you if
it is, or if it's not.
says it is. Yeah. And some points that we made on here is if they had a family history of vascular events, I don't know, like say rupture, like an aortic aneurysm or something. I mean, then maybe, again, that's scary. Probably be more.
But you're not really talking about that in your orthopedic visit.
No. I do not bring that up because I'll give somebody panic.
Yeah.
they'll never sleep again. They'll call every day and be like, oh my God.
Yeah, I don't necessarily think there's value in it. And again, that's me as a person, but me as a mother of a kid who's like, tell me every day that their body parts hurt. Like, I get it, but I don't think it changes anything. I think it raises awareness and it gives them an idea of like what to expect in the future. But I don't think there's any value to that in arriving at treatment. Yeah. Right?
It's not going to change the plan. So there are a couple of the most common ones we gathered to talk about that we see in our practice. So Beth, you see a lot of shoulder and knee. I'll see some shoulder, not quite as much typically. More geriatric shoulder in my practice.
Start with the hand and wrist.
So there's a couple different common hypermobility syndromes in hand and wrist, and you can get some in the elbow too. But probably one of the most common that we see is CMC laxity, like 20 to 40-year-old female, vague pain at the base of the thumb, wrist.
No injury, of course.
No injury. So you can get laxity at a couple different joints of the thumb that we see commonly. You can get it at the MP joint. So similar to if you have an acute injury like a skier's thumb from a UCL tear, or from like chronic use gamekeeper's thumb, or at the CMC joint. Those are the two most common ones that we deal with.
Now, when you see these patients and you're let's say it's a CMC joint and it's a female, because it usually is, and they're like, oh man, it just really hurts when I grip, twist, or do my hobbies, or even when they play sports. Will you what do your x-rays look like?
X-rays are sometimes normal. Sometimes you will see, though, that the first metacarpal is sitting a little bit radial to the trapezium, and so it is slid off a little bit, or it is subluxated a little bit. So those people, that cues me for a more slam dunk diagnosis for this. But you can definitely feel laxity in these patients. And they're typically gripping, pinching, twisting, twisting
things,
off a jar lid, things like that. And so for these patients, typically start with the initial treatment options, which are bracing, splinting. We can put them in rigid bracing for activity-based, just to stabilize the thumb. You can do taping like kinesio taping, which isn't going to provide a ton of like static stability, but it can give you some proprioceptive
Good
feedback.
For athletes,
Activity-based. And then a ton of therapy. Dynamic stabilization of the muscles around a joint is going to help decrease the mobility at that joint, increase the stability there. Therefore, you should decrease the pain, and hopefully, what this can lead to down the road, increased laxity at a joint just because of the increased motion there, early arthritis, just from that cartilage wear. So key focus is therapy, which is hard to get people to buy into.
I was just going to ask that. Yeah. Do you have a hard time selling therapy? And second question, do you use OT for that or use PT for that?
We use OT for it just because our OTs are very skilled in specifically working with CMC hypermobility, more so I think than the PTs I've worked with.
Yeah.
And one of ours is a CHT, certified hand therapist, so they just have a little bit more experience in it. I think buy-in, as long as my brain's working that day and I do a decent job of explaining it, it makes sense to them, right? This is moving too much. I need to get it to be more stable and move less, and then I will have less pain or less issues doing the things.
Do you inject people?
I will, depending on the age. And I don't know that this is like necessarily evidence-based. There's not really, maybe there is, and I just haven't looked into it, like data points of like, oh, this is the age that like now injections are appropriate. The younger somebody is, the higher my threshold is for that. And I tell people this all the time. Steroid injections aren't bad, but I'm not going to start doing them very regularly in somebody in their late 20s, early 30s.
But also important to explain to the patient that the steroid injection will not make your joint more stable.
This is a Band-Aid.
Yeah.
And so a lot of the times if somebody's younger, I will still get an MRI first just to rule out that there's not something that I'm overlooking and missing that is also causing it. And then I have a patient that like comes in once, maybe twice a year for an injection for it. It's just expectation setting that this is not going to be something that I can completely take care of, make all your symptoms go away. We're going to try and manage with therapy, bracing and splinting as needed. There are some surgical options for it. So if we get to the point where we've failed everything else for a significant amount of time, this is not like, oh, I tried therapy for 6 weeks and I still don't notice a difference, let's have surgery kind of thing. But you can do a capsulodesis, basically kind of plicate the ligament around that joint to shorten it or to tighten it up. Mm-hmm. And we also typically with that will do a selective joint denervation. So all of the nerves that provide sensation just to the joint, basically take those out to hopefully make them not have pain.
I have a patient, and I can't remember if you guys did it or not, but she is a massage therapist. So that CMC joint from getting in there like every day, multiple hours a day. So she had a CMC arthroplasty actually, just because it wanted her livelihood to. Every time she loaded, she subluxed, and she still has pain. Shocker, right? Yeah. Because again, the success rate with these patients that have surgery, if they go back to heavy loading of those joints, I mean, if their joints want to be loose,
they will be.
Yeah, they will be. You just can't really fix all of that. And that's a really, really important preoperative conversation to have.
Yeah.
But with this patient, we are doing periodic, I would say every like 4 months PRP injections just to try to stiffen up the joint.
Yeah.
And whether they work or not, because I don't TBD if they do, she continues to come back because that's for her to be able to do her job. That's the only thing. But
it is helping some clearly.
It is helping some, yeah. But even for this patient to inject her CMC joint after she had the arthroplasty, like I literally can open that joint up, no problem.
How old is she?
She's in her 50s.
Okay. Yeah. And I mean, that's like for an older patient, right? That's a more definitive claim for them is CMC arthroplasty. And we basically use like a suture suspension system to stabilize it. But I mean, like you just said, if they are, especially if they're somebody with generalized joint hypermobility, you're far more likely to, you have that genetic condition, you're going to continue to be lax, and you can't drink enough collagen to make up for that.
That's true.
Do you have patients ask you about that?
Yeah.
Collagen supplementation?
All the time.
What do you tell them?
Yeah, I mean, there's no downside to taking it, but it's not going to make your joints not loose.
Yeah.
So I think, again, it's people wanting an answer or a definition or a diagnosis, and then it kind of fixes them. But a really, big part of the conversation with whatever, hand, shoulder, knee, is that there's nothing that I'm going to do that's going to make your joint not lax.
Yeah.
And if I do, there's various risks for that, right?
Yeah.
So you do therapy, the risk is it's not enough. Or if you add a new activity, like let's say you want to play volleyball tomorrow, your shoulder's probably going to bother you.
Yeah.
Or, we can do an injection if you're going through a really painful time frame, but the injection's not going to tighten up your joint. Or we can do surgery to tighten up your joint. But, I think the complaint sometimes when you do surgery to make the joint more stable is that they're used to, whether they think it's abnormal or not, they're used to being hyperlax. So then you tighten up the joint. Now it's quote too tight. Well, I mean,
now they don't,
but it's stable. Yeah. Okay. I think as patients get older, their joint capsule will start to tighten up a bit more. So I think the need for surgery as you get older, it's less and less a conversation.
Yeah. Yeah. And I would say, we are very rarely doing these capsulodesis procedures compared to how often we're doing a CMC arthroplasty. Yeah. So for the most part, these patients are living with this condition. They have hypermobility. They may or may not be managing it with therapy and things like that in their younger years. And then when they get to a point where they have significant arthritis in the joint, we're doing the definitive procedure. Yeah. So,
but that's a hard conversation. Yeah. Like, hey, listen, if you wait it out long enough, A, it'll be stable, or B, it'll be so arthritic that I can fix it.
We do something. Yeah, exactly. Okay, let's talk shoulder. Do you feel like you see a good amount of this?
Yeah. So again, talk about not having adequate learning in school. I feel like this was one of those ones that I see way more in clinic. And when I first started out, was not necessarily prepared for how much I was going to see this. So, this is a kid who comes in, and again, female or male, I think generalized laxity in the shoulder spans anywhere from 40 to 70% of the population, whether they know it or not. So it's generally an athlete. It's generally an overhead athlete. It's generally a throwing athlete. So they'll come in with, oh, my shoulder hurts. Like with baseball, it hurts when I release, or, with volleyball, it hurts when I connect with the ball, or swimming, it just hurts in general. It pops or pops sometimes. It doesn't hurt when I sleep. I don't really feel weak unless I'm like in that overhead position. So their exam, if you don't know what you're looking for, is pretty benign. Like they generally have really good strength. The key with the multidirectional instability shoulders is that their joint, if you lay them flat, so they're in supine position, you can posteriorly and anteriorly translate that shoulder almost to the point where you can dislocate it.
Yeah.
So if you hold them in ABER and they just kind of like relax their arm, I can shift that thing out and back, and they're like
Job's
test, yeah. They're like, oh, do you feel that? Yeah, I feel that. And again, there's not really any testing on exam that's going to show you that unless you know what you're looking for. So, patients who come in, they've already Googled, or their mom has or their dad has, especially the baseball parents, and they're like, oh my God, they have a labrum tear. I'm like, like a throwing athlete, shoulder pain, teenager. Yeah, I mean, that is a possibility, but if I flip them around and do their other side and their other shoulder's the same, it's usually that multidirectional instability. Yeah. So we're talking mainly the glenohumeral joint. I've also seen it at the AC joint in the sagittal plane.
Interesting.
Yeah. So that's not really, really common, but we'll see that. Or again, the patient has pain right on the top of their shoulder, and you can literally take their clavicle and AP, to anterior to posterior, you can move that more than it should go. And the other one that drives me up a wall is the SC joint.
Ooh, yeah.
Yeah. So patients will come in with sternoclavicular pain. And when you look at their SC joint, even just looking at a person, when it is unstable, it's huge.
Yeah.
It's so big.
Do you remember I had that patient that I asked you about? I was like, oh my gosh, like it was actually just really degenerative too. But maybe because he had hypermobility there? I don't know.
Yeah. So patients get hypermobility there. But yeah, so the exam is relatively benign, but you need to know what you're looking for as far as anterior posterior translation. They'll even have a sulcus sign sometimes. The x-ray finding on really loose patients is you'll see their humeral head sitting a little bit more inferior. And again, the classic, urgent care patient will get a call and they're like, oh yeah, they're dislocated. I'm like, they're not. So, you take the lateral x-ray, their Y view, and it's not dislocated, but they'll just have that capacious capsule. And where it's capacious is inferior. So
capacious.
Yeah, you like that word?
That word. Yeah. I like that one. All right.
Yeah. So these patients, God, will I inject them sometimes? Like if it's a...
Do you have an age?
I hate the 18-year-olds when they're college age and they're athletes and they want the injection.
You're like, you're an adult.
18. Yeah.
But
so I guess that's the youngest, but it's just, strategically, like they're in season.
Yeah.
And I don't tell them not to continue to play, especially if their joint is, they have full strength and full mobility. It's just pain. I will do that for those patients, but it's the conversation of you really need physical therapy. So the shoulder joint, I always compare it to the hip joint. So shoulder joint is ball and socket, hip joint, ball and socket. If you look at the glenoid of the shoulder joint, it's like a plate. It's so damn shallow. So you require a lot of ligamentous stability in order to, have good mobility. Wait, am I saying that right? For stability of the joint, you rely on your ligaments.
Yeah.
Now, let's say the ligaments are lax. Now you rely on your dynamic stabilizers like your rotator cuff and your scapular muscle. So explaining that to the patient, like, hey, you see how I can move your shoulder around?
Yeah.
That's why when you take it in a stressful position, it hurts. So I struggle when I send these patients to physical therapy with the physical therapist, and not all of them, but some of them, they'll do rotator cuff strengthening. And like, that's great, but it's more stability exercises.
You need the dynamic stabilizers.
Yeah.
Like
so I will see,
on the ball.
Ball on the wall.
Oh, yep.
I will see these patients come back and like, oh, it didn't help. Which, then I have to have the conversation of like, well, your therapist didn't do the right job. So they always, and I really, really say always, because they always do, want an MRI.
Yeah.
And again, for those practicing PAs, MRI arthrogram. Okay. It is generally normal, but if you have a good radiologist and if you look at it yourself, you will see that, Hannah, capacious capsule.
Capacious capsule. Oh my gosh. So I've been wanting to bring this up. What about like the incidental findings on these, right? Like you have multidirectional instability and that is what is causing your symptoms, but you've got this tiny labral tear, right? And they're hyperfixated on it because and they're like, this needs to be fixed. This is clearly my problem. And you're like, if you go to someone and they fix this, you're going to be back.
So I'll tell you what, so anecdotal, we had a college student, I think at Liberty or somewhere where it was like not in state, and seen someone else in our practice, MRI arthrogram, slap tear, and wanted to do everything virtual. Like wanted to do like, oh my, the doc saw me, said I need to meet you and set you up for surgery. And I was like, well, honestly, you're a swimmer, right? Yeah. Okay. Well, I just did a video interview with them. And again, I asked them to extend their elbows and thumb. And I was like, oh my God, hyperlax. So I said, listen, like if we're going to go in and fix your slap tear, which may or may not be even there, your real problem is the fact that you're unstable and you're a swimmer. So we did end up fixing her slap tear. Didn't do anything else for her because she wanted to continue to swim, which again, caveat, if you tighten up these people, sometimes they can't go back to their sport, right? Either they don't have the mobility to do that. So she rehabbed, went back to swimming, and then I saw her not too long ago. She's like, hey, my shoulder dislocated. I'm like, no shit. Well, it just is one of those things. I know. It's one of those things where, if they have that generalized laxity and they don't treat it the right way, surgery is not the most effective.
That's why MRIs can sometimes be evil.
I know. And I'll tell the patient, like, I'll get an MRI for you, but it may be completely normal.
Yeah.
And that doesn't mean you don't have a problem. It's just, it's not the problem that you think you're looking for.
But this is like education based too. Because again, you have to have these conversations. Like we see this a lot. I feel like I don't know what your number one incidental finding that you're like, crap. but it's TFCC tears
for
me. Yeah. Like, everybody's got a little central perforation in their TFCC. You do, I do, we've all got
We're
it,
not
right?
operating all of those people.
That's not what's causing your symptoms most of the time.
But surgically, we will fix these patients by doing a capsulorrhaphy where we essentially tighten the capsule. So the doc I work with loves the comparison of you take a pair of wide-leg jeans and you make them skinny jeans. That is literally the surgery. You kind of like hem it in.
I've heard that comparison before. I feel like I've seen this movie before.
But with those patients, if we do zero therapy, they actually do just fine. That's how powerful having a lax joint is. Like if you tighten it up and you do no therapy, they actually get the range of motion back. So we'll treat them for 3 months of no therapy.
Yeah. Sling for a long, long time.
Yeah. Sling for like 2 months. And then they just don't get stiff. It's just not something that we have to worry about.
And then let's touch on knee as well. Because when we initially brought up doing this, you mentioned patellofemoral instability. And this is a big one.
It is a big one. And again, this is a really hard one if you are starting out seeing patients in an orthopedic setting, because again, we're talking about habitual instability, not traumatic. Mm-hmm. So some patients, if you're lucky, the textbook will tell you, you take if it's a young patient, your 3 view and you're looking at your sunrise view and your patella is either tilted or it is subluxed or it's both, right? And then you're like, oh my God, that's what your problem is. Sometimes it's completely fine. Like you'll take that sunrise view and it looks fine. It's lined up perfectly and you're like, wait, isn't it? But where patients will predominantly present with hyperlaxity in the knee is that patellofemoral joint. So it will be, again, it's very common with the hand and the shoulder. It pops. It hurts when I go up and down stairs. When I bend and straighten, I just feel it crunching. So recurrent subluxations, some patients will say that. But again, if you're living with it and it's quote normal, some people don't even know what's happening.
Yeah.
So when you do your physical examination, again, with the knee, you'll see that the knee hyperextends 10 degrees and it does it on both sides. So you'll take the kneecap and really try to laterally translate it and patellar apprehension sign if when they're like, oh, that hurts. But a lot of them are like, that doesn't hurt me.
It's fine. Yeah. But it just moves a lot.
It just moves a lot. Yeah. So hypermobile, they have no real positive provocative testing. So it's a very benign exam. And again, you'll see these patients that come in and their parents are like, but they do dance and it hurts so bad. And, they're a professional dancer at 13. And that's really hard because when you see it at 13, especially in females that are just like in the midst of or beginning puberty, like, girl, this is going to bother you until you're 18, especially if you're jumping, landing, repeat. So the education is huge, like explaining what the situation is. And for females, if the angle from their hip to their knees is greater, they just have more stress on the knees.
Yeah.
If their quads are garbage, their knees are going to bother them. If their glutes are garbage, their knees are going to bother them. So explaining that to a patient who already maybe did a little bit of physical therapy, I'm like, hey, you're going to go back to therapy and you're going to do probably many, many rounds of physical therapy.
And people don't think, like, people are like, oh, well, I'm already, like, I work out on the team.
Yeah,
like, why do I need therapy? Well, your sport that you're doing, you are likely a hamstring dominant athlete or, like you've got a great imbalance between what you are focusing on most of the time and what you need to balance focusing on.
So we use also, besides therapy, because sometimes therapy is hit or miss, we use a power plate. So power plate's huge for patellofemoral pain.
You stand on it.
Yeah, vibration plate, just don't fall off. Yeah. But that one that helps fire, what do we tell them? It's like drinking from a fire hydrant, right? So you get all the stimulation and your muscles can't decide which ones to favor. Like if you're hamstring dominant, it's not going to let you be hamstring dominant.
Yeah.
Or if you don't preferentially fire your glutes, you will, just to fight the vibration that's happening.
Like riding a bull.
Yeah.
Is that a good comparison?
But those patients, so taping is huge. Bracing is helpful too, but the buy-in with therapy, I will say a lot of those will go for second opinions.
Yeah.
They just, or I'll see a lot of them that are second opinions. Injections, hit or miss. And I hate injecting, the teenage.
A young girl with patellofemoral. Yeah. Like what are we doing here?
Yeah. So to compare it to CMC, the population that is so difficult is the 45-year-old female who never knew that they were a little bit lax and now have a little bit or moderate chondromalacia and now it hurts starting. And it's my meniscus and I need an MRI, and you get an MRI and you're like, girl, no, it's not.
Yeah.
And then
but they do have a little meniscus tear.
They do though, because the MRI will say that they do. But no, those are so tough. Those are so tough. So surgeries that we would do to fix that, we can do MPFL imbrication. So plus and minuses with that. Those are hyperlax patients that have atraumatic dislocations. And those are ones that you can like literally dislocate just looking at them. Lateral release sometimes. But again, the doc I work with, we could go on and on about this. It's just not, it's not the fix, right? So if you do that, you have to sign up for therapy. And a lot of them are at the point where like, I'm not done therapy and I don't need to. Like I work as a vet. I'm on my feet. So the combo therapy, if we were to do any type of surgery, is doing the physical therapy. But those are long recoveries.
Yeah. Yeah.
So, I mean, I'll talk about the elephant in the room. So when you see a patient on the schedule, right? And let's say they're coming in for their wrist or their CMC joint, it's always like, the typical patient, it's a hypermobile patient. It's like Brittany or Brandy. It's always a patient whose name ends in a Y. They're a redhead. They got a ton of freckles. Their pain control is minimal. Like that
we know
is
who
the
they
patient.
are. We know who they are before
you go in the room.
Yes.
Like I don't even know. I know that's not stereotyping, is it? Like Brittany's.
No, I mean it is, but like.
But that's the thing.
Stereotype certain things. Yes.
Yeah, that's a real thing. So you'll see that patient on the schedule and you're like, before you go in the room, you're like, I know it's hypermobility.
Yeah.
Like, I know it is.
Yeah.
When I was looking into like putting an algorithm together for this episode, it came up with multidirectional Billy. Describe the archetype: red hair, fair skin, poor pain tolerance, non-athletic, hypermobile. I'm like, it's never Billy, it's Brittany.
It's Brittany. Yeah. It is Brittany.
But again, will I bring that up? Yeah. I mean, sometimes these are syndromes that patients have, and you know, I like to make them aware of that, right?
Yes, yeah, like you fit the bill.
Yeah, but also it's not Brittany. Every redhead. It's not every redhead who has shoulder pain does not have instability. So really taking the bias out of it, you know, until you see and lay hands on the patient.
Do you I mean, obviously this is much more common in females. I'm like trying to think of the last time that I saw a male. Shoulder for sure.
Yeah.
Like, you know, baseball overhead athletes.
But a lot of the males.
Patellofemoral?
No, a lot of the males are traumatic. Like they're not what we are really talking about, but they have their instability secondary to traumatic things.
Yeah, they tore their MPFL
but I've had a couple males that have had MPFL reconstructions and few and far between.
Yeah.
But again, it's that undiagnosed EDS patient.
Yeah. And I also, again, not to stereotype, but these are the visits that sometimes can be they can go one way or another.
But they're also abstract. Like you are abstractly explaining to them, especially when their x-rays are normal.
Yeah.
You're showing them that you theoretically have a collection of things that equal hyperlaxity. And they're like, yeah. Like,
it's
sometimes they don't buy into it. It is.
Yeah. I mean, obviously, this is a much different visit than like you broke your wrist. Like I have a very easy solution.
Look
for
at the picture,
right?
Yeah,
you would think that a very complex wrist fracture and explaining, you know, what we're going to do and how we're going to fix this and all of those things would be a harder visit than somebody like, oh, your joint's hypermobile, you just need to do therapy, and it's like totally the opposite. Yeah, I'm going to knock out that wrist fracture visit in like 5 minutes. Here's our plan. The other one's like 45 minutes.
Yeah, it is. I have a vet. She's like vet assistant. She's late 20s, early 30s, and hyperlaxity, right? So she came in because she has knee pain because she's literally going down into that full squat on the floor and up and down and up and down and then kneeling. So it's the pressure on the knees too. So she came in to see me, and I literally did a great job. Like I thought that I explained to her, and you know, there's something unfortunately with your occupation, which you're not going to quit your job.
Right.
You're going to have to work through. And let's start with, you know, tape and a brace, and then we'll try therapy, we'll try power plate, and then come back and see me. So she came back, but went on the doc's schedule, right? Because they need to get to the bottom of it.
And yeah, the answer you gave wasn't
enough. So the doc, which you have to, well, not have to, but we can order an MRI scan back to me to go over MRI results. And it's normal, you know,
my heart rate.
I know.
Made it spike a little bit.
I know. So it's very difficult. But again, I do think having the picture of the MRI and showing them what the negatives are, you know, like it's not this, it's not that, it's not this. It is unfortunately just your kneecap. Like we went over 8 weeks
It's the
ago.
first thing. But sometimes you do need that. You need that for the buy-in.
And so what I said, I went over with this girl and I said, you know, you do sit a little bit lateral, like she's tilted a little bit enough where, you know, she's like, oh, that's it. That's why. And I ended the visit and she had said, well, you know, just worst case scenario, like people don't require surgery, but like how long would you wait trying doing what I'm doing? And I'm like,
I hate that question. Yeah.
Because she came in because she wants us to quote fix it.
Yeah.
But the fix for that one may be a lateral release, but a lot of therapy. And guess what? Your knee's probably still going to click when we're done.
And then you're still going to probably develop some patellofemoral OA in a couple of years. And then we'll start euplexa. And then we're going to head down this whole road and you'll be like, wow. Yeah. She never fixed me back.
She didn't know. And then you'll get a meniscus tear or you won't, right? Oh God. They're just really difficult visits. But I think the key here is understand it is a clinical entity. It does affect, and again, we're talking about the things that interest us, which hand, wrist, knee, and shoulder. You'll see it in the elbow. You'll see it in the ankle. You'll see it in the ankle. And there are stability procedures that you can do for all of that. You'll see it in the spine.
Hip.
Hip and spine. You'll see it everywhere. So recognizing it, educating yourself so that you can have that appropriate conversation. But again, it's not anything is terrible. Don't say that. It is something. You have to validate like what it is. But I think that one doesn't translate from the book to clinic.
Yeah. I think you need to have this on your mind, somewhere in the back of your mind when you're evaluating patients, because otherwise you could leave a visit with, okay, your x-rays are normal. You don't have CMC arthritis, or I don't see any degenerative change yet on the x-rays. X-rays are normal. I have nothing to offer you.
Yes.
And then they leave like, okay, you did nothing for me and I have no answer to this. I mean, this is giving somebody an answer and a solution to it. But even though it's not, you know, a light switch gonna fix the problem.
And sometimes they want it to be like a meniscus tear. You know what I mean?
Yeah.
Because
then I wish it was just broken.
I know. You know what? I do too. Because then this would be a very easy conversation
for me too. I also wish that it was broken. Yeah. So keep it on your radar. In the radar. All right. I love it. Talk. Well, if you guys have any more suggestions for us on things that orthopedic topics we should go over, shoot them our way, because I feel like we enjoyed this.
I do. That was really good. Yeah. I feel good about that. Perfect.
All right.
Till next time. Thanks for tuning in to Joint Effort PAs. If you enjoyed this episode, be sure to subscribe, leave a review, and share it with a fellow PA or med-minded friend. You can also follow us on Instagram at Joint Effort PAs for updates and extra content. See you next time.